So good morning, everyone. I'm Steve Scheinthal. I'm the Associate Director at the New Jersey Institute for Successful Aging and the Chief of Geriatric Behavioral Health. And today what we're going to talk about is a little taste of the geriatric patient from a psychiatric perspective in the emergency department. Also joining us this morning is Christian White. Many of you may remember Dr. White as a student and as a resident, and he's now a geriatric psychiatry fellow. So, and we're glad he's with us as well. So what we're really going to cover in terms of the patients today is we're going to take a look at suicide in the elderly. We're going to talk a little bit about substance use. We're going to talk about the real agitated patient that comes in who's older and how do you appropriately manage that. Everything that we're going to talk about this morning is evidence-based. It may not be what is common practice for all of you, but know that as a backup, this is what the evidence is saying, and that's why we're presenting it, and it may expand the way you're treating your patients and help you to improve your care. As many of you know, we're opening geriatric specific beds at the Stratford ED, and I think that that should be a really nice addition to the Kennedy care system. So this is our first pretest question that we're going to cover. You've all graduated medical school, so I think you can all read. Let me know when we're ready to go on. Everyone good? Anyone not good? Okay. So here are the questions. Which of the following risk factors should raise your concern about this patient's safety? And, all right. So the vast majority of you said that the answer is E, the loss of the patient's wife. And that's really the correct answer. That would be the greatest risk for suicide in this population. Is losses. And it's not only loss of a spouse, it could be loss of a pet, could be loss of income. There are a lot of losses that these people suffer. So we'll be getting into that in a little bit greater detail. So here's the second question. So here's the question. What's the most likely diagnosis? Okay, so about half of you felt that the answer was alcohol intoxication. About 40% felt that the answer was brief reactive psychosis. 3% of you felt that it was schizophrenia, and 3% felt that it was cannabis formaldehyde intoxication. The correct answer here actually is the cannabis formaldehyde, or wet, and we're going to get into detail some pretty surprising statistics about substance use in the older adult. You usually don't get psychosis and paranoia with alcohol intoxication, and that would be the giveaway there. So this is the third question. Do you remember this case? You and I had this case. Just another typical day in Cherry Hill, right? You ready? Okay. So the best course of action for the safety of this patient and your staff is so more than half of you felt that the answer was 2 milligrams of Haldol IM. The next most popular answer was to do the 5 milligrams IV and then a smattering of other choices around there. And the correct answer here is actually the 2 milligrams of Haldol IM. IV Haldol is not FDA approved and poses significant risk factors for everyone, and we'll get into that in a couple minutes. So one of the things that many of you have had me as students remember, and we know is still true, is there's tremendous stigma about the older patient coming into the emergency room. Samuel Shem's groundbreaking book, House of God, that came out in 1972, while we would like to really believe that things have dramatically changed since '72, they haven't. And we know that there's still a lot of stigma associated with the older adult, and there's a lot of reasons why people just don't like to treat them. And they get pushed through their system very quickly, and often things get missed. One of the things that I'd like to just help you all realize is that psychiatric illness, mental health issues, actually break out by age. And so you can really be able to pinpoint diagnoses or shift diagnoses based on how old someone's coming in, and the history becomes incredibly important with the older patient. So for example, the 80-year-old who presents with no prior psychiatric history and someone's telling the family they're bipolar, they're not bipolar. Bipolar disorder is not going to emerge at age 80. You're not going to get a new onset schizophrenia, back to the pretest question, in someone who might be in their 70s with no prior psychiatric history. Just won't happen. There's a late life variant of schizophrenia that emerges around age 65, 60, 65, but there would be a history of odd behaviors before that. Someone just doesn't have no history and then becomes schizophrenic in late life. So those are important tools for you to keep in the back of your head, because they'll help you really ease people over into delirium or more appropriate diagnoses when they're presenting. When psychiatry talks about diagnoses, we often use a 5-point axis system, and you may see this coming in on consult sheets, you may see this on write-ups, and I just wanted to make sure that you're all familiar with this. It may have been a while since your psychiatry rotations, but just to touch on it, axis 1 are major mental health issues. So depression, schizophrenia, bipolar disorder, dementia will go on axis 1. Personality disorders and developmental disabilities appear on axis 2. Axis 3 is what all of you are very familiar with. Those are major medical diagnoses, and we know that they go hand in hand. The data is becoming overwhelming that depression and cardiac disease are linked in ways that we don't yet understand, but we understand that they are linked. Dementia of the Alzheimer's type is linked with Alzheimer's disease. Medicare actually requires that we code on both axes for that diagnosis. Axis 4 are psychosocial stressors, patients that may have legal problems, housing problems, financial problems. That's what's on axis 4. And axis 5 is a global assessment of functioning that ranges from all of us, which on any given day we probably function at about in 75, 80 to 90. No one functions at 100, down to about a 10, which is someone who is actively suicidal with intent and plan. And that's pretty much the range there, and those are the numbers that you're looking at. What's important to understand when you look at the DSM, the Diagnostic and Statistical Manual, is that most mental health diagnoses are excluded based on an underlying medical illness that may be causing it or a substance use. So what you often see that may be very incorrect is someone who comes in with a high blood alcohol level, has no prior history, and someone's writing that they're depressed instead of substance-induced mood disorder, which is the more accurate way to go, because that's linked to the alcohol intoxication. You'd want to know if, with no alcohol on board, were they in fact depressed? And the way we often diagnose, we don't ever get to that point. We're very quick to label someone, but not necessarily accurately. Just for your reference, schizophrenia is really a disease that emerges in late teens to mid-30s. So unfortunately, many of you are still at risk. And then we tend to see again back in 65 to 75. But again, these people would be odd, eccentric, lifelong. They wouldn't just be functioning like on a regular basis and then suddenly have a psychotic break. Bipolar disorder is a disease of the late teens, early 20s to 30s. This affects men and women about equally. Major depression, women seem to be greater than men and can occur pretty much at any time across the lifespan. Anxiety disorder, again, women greater than men, and again, can be over the course of the lifespan. Dementia is pretty significant. We know that about 50% of the people who are greater than 80 at some point will be affected with some sort of cognitive disorder, which is pretty striking when you think about it. Delirium, obviously acute onset, caused because of an underlying medical disorder. This is a medical emergency and really resolves when you treat the underlying medical problem. Psychiatry can be helpful in managing the aggression here, but really isn't necessary for someone who's acutely delirious. So, another question for you. What's the most common psychiatric disorder in the elderly? So, more than half of you answered C, depression, which is the correct answer. The numbers are pretty impressive here. In the community-dwelling elderly, which is who you're mainly seeing, except for the people that are rolling in from the nursing homes and assisted living, about 5% we know today, this is very recent data from 2011, 5% are meeting the criteria for major depression, which is impressive. What's more impressive is that about 8 to 16% of the community-dwelling older adults are meeting a subsyndromal depression. So they don't meet full criteria for major depression, but they have depressive symptoms. They may be apathetic, they may just not feel like doing anything, but there is definitely something going on here. And they're coming in. We know that these people are heavy users of mental health services, but also heavy users of medical services. These people have a greater likelihood of dying because of the depression, and we also know that these are the heavy ED users. These are the people that just keep coming back and coming back and coming back, and you may refer them for psychiatry, but they still keep coming back because they don't meet criteria for admission, but they're not accessing services in the community. They may not have access to a primary care doctor. They may be inadequately treated. The challenging issue is that the literature is starting to really suggest that for this population, medication doesn't work. That we're really not seeing that the medications are effective in this group of people. And that may be one of the reasons that they're more frequent users, because they're looking for something, but they're not able to access it. And we know that depression will also prolong hospital stays. Just for completeness, this is the Diagnostic and Statistical Manual criteria for depression. So you're really looking for 5 or more symptoms during a 2-week period that include things like depressed mood, diminished interest, weight loss not due to dieting or weight gain, insomnia, agitation or retardation in terms of their energy level, fatigue, feeling worthless. Older adults frequently won't say that they feel guilty about their life, but they may feel that they are worthless, that they haven't accomplished things. Having trouble thinking or concentrating, which is hard with the older patient because that may lead you more over to a cognitive disorder. But it could in fact be depression. The old term for that confusion was pseudodementia, which was eliminated in the 4th edition of the Diagnostic Manual, and I think many geriatric psychiatrists wish it were back because it's a syndrome that we frequently see. And recurrent thoughts of death, not just being afraid of dying, but really wishing that they were dead and thinking about plans. And that's the difference, by the way, back in the pretest question between a death wish and being suicidal. You want to know that the person, is there an intent and is there a plan? So one of the things that we see a lot at NJISA in the nursing homes are patients who are in a nursing home who say, gee, I'm going to kill myself. And you say, oh, how are you going to do that? I'm going to shoot myself. Well, there's no gun. So, you know, is there a realistic plan even though there's intent? And we try to tell the staff we're not sending someone to the emergency department who's saying they're going to shoot themselves without a gun. That's something we can manage by observation and engagement. So the risk factors here for depression include medical illness, functional disability. You know, if you think about older adults and they may be not as easily able to climb stairs, to dress themselves. You know, if you think about the mechanics, I see many of you are wearing t-shirts. To pull on a shirt in the morning is very hard because you got to get your arms up, and a lot of older adults, due to degenerative joint disease, may not be able to get their arms up. A lot of older adults, because of arthritis, can't manage buttons on a shirt. And these are frustrating losses. They may have trouble getting up and out of a chair, and that may be causing them problems. They may not be able to drive because of visual problems or because of functional mechanics of getting in and out of a car. That's another loss for them and a functional disability. There's a lot of stressors in getting old. You know, with the market fluctuations, we're hearing of people who have trouble deciding, can they afford their medication or can they afford to go and get meat for dinner? And that's a hard decision for some people. A couple years ago, when the market first crashed, in the office we were hearing patients say, gee, I don't know if I can afford my medication or heating oil. And those are really choices that none of us want to have to make, but the people we're seeing may be struggling with and may not feel like bringing that out in an emergency department, and then what do you do? Because it's really a social service issue, but it's really impacting that patient. And again, losses are very big. People are losing partners, they're losing spouses, they're losing friends, they're losing their independence, they're losing pets. How many of you own a dog or a cat or any pet that you're close with? You know, imagine how you would feel when your pet's gone, but imagine if that's the one thing in your life that's giving you happiness because you're living by yourself. You know, it might be easier to come in. You know, the nurses are really nice in the emergency department. The doctor smiles at me. You know, people are touching me. Many of these patients, you know, to hit on our osteopathic roots, many of these patients no one has touched. And so just by laying your hands on someone, not doing OMM, but actually putting your hands on them may be therapeutic because that may be something that they haven't had in a long time. When we miss depression, what happens is that we know that medical services start to get overutilized. The challenge is once you recognize it, do you have the resources available to you to make the adequate referrals? And the community resources here are limited, and some of them are hidden. There are actually some geriatric care managers in the area which we may or may not be aware of. One of them just toured the new ED in Stratford to take a look at what the setup was going to be for geriatric patients. But these are great resources that are out there that help provide a safety net. And there are a lot of resources that are very quiet and functioning under the system, and what you may need to do as you go out into your practice is you may need to reach out to the geriatric providers in the area and then be able to decide, you know, what would be helpful for me to utilize and create a resource book. Because those resources also shift as funding shifts. And for example, with a geriatric care manager, very often that's an out-of-pocket expense. So if someone's, you know, self-pay, that wouldn't be an appropriate resource for them because they're not going to be able to afford it, and you're going to just drive their frustration in helping them realize that what they don't have. So, what is the highest risk group for completing suicide? So, interesting split. 40% of you are saying 60 to 70-year-olds, and 30% of you are saying 80 to 90-year-olds. About 20% are saying 25 to 35-year-olds, and 40 to 50 are coming in third. So what we know is that the first age group, the 12 to 20-year-olds, are the highest attempters. That they will make attempts at suicide, but they're not successful. And there are more cries for help, but they don't complete. The greatest risk group for completion is the 80 to 90-year-old group, actually the 85 and over group. And that statistic has stayed pretty constant. There's some data I'm going to show you that is very current out of the CDC. And we know that this age group, actually the number is jumping. And the fear is that as the baby boomers start aging into their 70s and beyond, that this number is going to climb even higher because the cohort group will be higher. Currently, the second highest group is actually the 25 to 35-year-olds. If you look at the CDC information, it's the second leading cause of death in that age group is suicide. So this is a real case that some of you actually may have seen in Cherry Hill. 78-year-old man. He's a former concentration camp survivor. Wife passed away 6 months ago, and the kids realized he really couldn't care for himself, and that's how he wound up in assisted living. He's not eating. He's very withdrawn. He's hopeless, and he's helpless. And he actively states life's not worth living. So, what we know is that 60% of these people who are completing suicide have seen their primary care physician within a month of the suicide, which is pretty high. And that's not that the primary care physician is not doing a good job. What that is these people aren't coming into their primary care doctor and saying, guess what I'm going to do? They may be collecting the tools necessary to complete suicide. They may be asking for more prescription drugs, but they're not being completely upfront about this because they're using more lethal means. Remember, this is a completer group. These aren't people that are asking for help. These are people who are looking to check out. So when we talk about the risk factors here, the number one red flag when someone comes in to see you is older white male. That is consistently the number one risk factor. And that's held, by the way, since about 1990. There was a feeling, a very strong feeling, that was going to shift, that as women and minorities were getting more access to higher positions in the workforce, that we were going to see an erosion of it being the older white male. But interestingly, the suicide rates for women and for African Americans, both male and female, have stayed the same or dropped. We haven't seen them climb, and older white male has really held as the number one risk. Very often this is someone who's single out of choice, or single because of divorce, or single because they're widowed. But these are people who are alone. And when you ask them about friends or family or additional contacts, there is no one else for them to contact. These are people who are very isolated. And it's not really clear why they're so isolated. One theory is that these were people who were married to their jobs, and so that was their whole life. And then when they're out of the workforce, they had nothing else to do but be by themselves because their work was their whole life. Multiple medical problems. And if you think about that, the more pills you take, every day you take the pill, or when you're taking the pills during the course of the day, it's a reminder of how sick you are. And so they're getting a reminder every day that they have all these medical problems. And that's before we get into can they pay for their medications and how are they paying for their medications and that type of interaction. Just one other issue that's come up with medical problems, as more people move to pharmacies that deliver, in this population that's actually a problem because it's decreasing human interaction. if they're using a mail order pharmacy, they can get their medications without ever interacting with anyone, which further fuels the isolation. We also know that alcohol usage or any substance usage raises this problem, and in elderly suicides, that number may be as high as 44%. And we'll cover why it's a very significant problem in a couple minutes when we get into substance use, but alcohol does funny things, and the way it's marketed is pretty interesting. So these are the most current, this is the most current data. This is actually out of psychiatric clinics from June of 2011. And what we're seeing that's really profound is this is 45 people per 100,000 of older adults. It's compared to the general population of about 11.5, and in the 30 to 34-year-old group, it's about 21 per 100,000. So they're more than double the 30 to 40-year-old group, and they're 4 times the general population rate, which is striking. And especially when you compound that with the percent that have just seen their primary care physician within 30 days, the onus really falls flat in your doorstep if these people present, because no one else is going to be picking it up. So how do you get this out of these people? Well, you want to know, were there any prior attempts? And they may not tell you that. I know over in the psychiatric emergency service, we have patients all the time who say, I've never been here before, and then you pull up on their EMR, and suddenly, you know, they've been here 5 times in 5 years, and they're all the same suicide attempt. You know, how does that happen? Because they don't want you to know. You want to know if there's any history of depression, any substance abuse. What is their social support like? The question I'm very fond of asking is not, were you trying to kill yourself or are you suicidal, but do you feel life is worth living? Which is a much softer way of approaching that. And then if they say no, the question is, would you ever think of doing anything to take your life? So you're engaging with them on a more personal basis, and it's not a question they're used to asking or answering. And they tend to be a lot more honest with that type of approach. So that's a little tool for all of you to have. And you want to know, has there been a lot of losses lately? Have their friends passed away? Have they lost partners or spouses recently? Did they have pets? Are the pets gone? I'm hearing that more and more, which is why I'm bringing that up. So you want to know about these losses, and you know, it's okay to ask, you know, have you taken a big hit in the market downturn? Because that's a big loss for these people too, and they may be very worried about, can they afford their living situation? You know, in which case it's easier to check out than to keep worrying for these people. So who abuses alcohol more? Is it guys or is it women? That's great. So hopefully you're not answering from personal experience, and I'm not going to give you the answer. We'll get to what the most current data says. But there's a follow-up question to this. That's great. That's never happened. So the follow-up question is, who abuses prescription drugs more? And 67% of you are saying that it's women, a third of you are saying that it's men, and again, we're going to get into this. So the most recent data that we have, this is 2011 data, is saying that it's getting close, which is really interesting based on your results. Older data shows a much bigger spread between men and women, and men clearly were drinking a lot more than the women were, but the most recent data is showing that slightly more men drink than women, which may be a relationship to workforce issues, it may be a relationship to a whole bunch of other socio-economic issues, but that's where that pans out. What really is striking is that this is 30-day usage. numbers. And these are people over 60 who are saying that they're using marijuana within the past 30 days. And I always wonder about these studies, because if someone came up to you and asked you to fill out a survey, or a Survey Monkey, or you were at in the mall, the survey people that accost you, how many of you are going to be honest about this? I mean, so I'm always impressed, but it also helps me understand that these numbers are probably higher than what we know. And that was the reason for that question. We know that in this study, 12.3% of the men and 4.2% of the women were using marijuana within the last 30 days. And it's amazing when I'm talking to my patients. There's an 80-year-old patient that I have who is on the internet, on multiple websites, not looking for a drink, but looking for a lot more, let's say. And she talks about how lighting up before or after with a joint is very pleasurable to her. She's 80, and she does this regularly with her multiple partners. There are people who are younger than that who are traveling to Europe and think, it's great to go to the Netherlands until the recent change in the law, because they could get marijuana for free. And it's not something you would think about unless you ask. Because they look cute, they're older, we love treating them in geriatrics, and yet they're users. And it becomes a real problem. And that's before you get to, are the kids supplying them? You laugh, but have you ever asked, or have you seen in the emergency departments here, where the parents are partying with the kids? And it's really kind of like a twisted world. Within the past year, the numbers get a little bit more staggering. And remember, these are people who are over 60, and this study actually goes up to 85. Opioids, about 9% of the men and 1% of the women. The incidence of schizophrenia in the general population, gang, is 1%. For 1% of the women to be using opioids, that's pretty striking. Never mind the 9%. Amphetamines, you're seeing 5.3% of the men and 2.1% of the women. Sedative and hypnotics, 21% of the men and 18% of the women. These are not things that we commonly think about when we're seeing older adults hitting the door of the emergency department. But you really need to be very sensitive to that, because it may be clouding what's presenting, and you may not think to get a UA, a urine drug screen, on an older adult, but maybe you should be, because you could be really surprised about what's showing up. The answer to the pill question is women are the higher users. And if you have any doubt about that at your next holiday gathering, happen to mention at the dinner table that you have a headache, and suddenly CVS will appear on the table as everyone rips open their pocketbook and is offering all sorts of medication, from Xanax and Ativan to Valiums to Motrin. And you'll reinforce that question. So when we look at the difference in terms of coming up with a correct diagnosis here between abuse versus dependency, it's a little bit hard, and it's hard in the older adult to do this. For someone who's abusing, they may be missing obligations. They may be social drinkers. They may say, oh, I drink when I go out with friends. But how often is that? Or especially in an older adult who may go out every night. Are they drinking daily? With dependence, there may be unsuccessful efforts to quit, and they may have tolerance and experience withdrawal symptoms. Not all people who are dependent will experience withdrawal. And that's important to know for the populations that come in who are using alcohol and saying, I need medication for my withdrawal. Well, what are the objective signs and symptoms of the withdrawal before we give them medication that may be the reason they were coming in the first place for? What makes it difficult in the older patient is that if you think back to the physiology, sorry to give anyone nightmares about physiology class, but the older adult physiology is different than the younger patient. These are people who have increased body fat. Even though they may not appear to be overweight, their lean muscle mass is diminished, and that's been replaced with body fat. They have a decreased total body water, and they also have a decreased alcohol dehydrogenation in their system, so it's harder for them to metabolize. This is, by the way, a real ad. And this is why older adults who are isolated may also drink, because the promise is, look at all these people, they're having a great time. And I feel lonely, so why not drink? Because maybe I'll feel like this. You know, Madison Avenue has great effect. The way older adults may present, though, to all of you is you may get a history of, I'm falling a lot. Well, why is someone falling a lot? Is it a degenerative joint issue? Are they a past stroke victim where they have balance and gait problems? Or is there something else going on? When you hear falls as a complaint, that's one of the things you have to think about. Is there excessive irritability? Is the family talking about them being more irritable than usual? Are there sleep problems in a person that never had sleep problems before? Sudden onset of confusion, while it could be delirium, while it could be an underlying dementia, could also be a substance issue. And it's hard to tease these apart. These are issues that take time and a little bit more detective work for all of you. And you have to get beyond the stereotype that, you know, they're 78. They're not going to be using anything, because that's where they'll get you. You want to take a look at the whole picture, and more, you have to think of these people as using and active. You know, if you think of whatever it is, 60 is the new 30 or 40 or whatever it is, you know, if everything has been moved down, these aren't the 80-year-olds that you may remember when you were young who were your grandparents. These are a very active group. I just had a medical student yesterday who was asking what's the cutoff for aging and why, and I said at SOM we define that as 55 because that's when physiology starts to change, and she said, oh, my parents will be devastated if they hear that. They're 61 and they don't act that at all. Well, what is acting 61 really like? Does that mean you don't drink anymore? Does that mean if you were partying with your friends, you've stopped that? You know, we could put our own social mores on that, but the reality is these people are living different lifestyles than you and I may anticipate. So there are a couple good screening tools and a couple bad screening tools. So the quick and dirty one that you may remember from medical school is the CAGE, which is cut back, annoyed, do you need an eye opener, do you feel guilty? But the problem in using this with older adults is they may not feel guilty about their drinking. That may be something that they enjoy and they're going to hold back from you. Often because there's no tolerance in the older adult, they may not need an eye opener. So you would take out two of the risk factors here, but important to mention just to refresh your memory on quick and dirty alcohol screening. The two really good tests are the MASG, the Michigan Alcohol Screening Test, Geriatric, and the short, the MAST. The MASG was specifically designed for the older user, but it's a very cumbersome tool to use and not probably helpful in an emergency department setting, but could be. The short Michigan alcohol screening test has great validity in the older patient. It's a 13-item test, and it looks at longitudinal alcohol use. And what's coming out in the substance use data in the elderly, which is a relatively new field, is that it's the longitudinal history that's perhaps most important for you in terms of making an accurate diagnosis. Not just when did you drink last, but when did you start drinking? How many years have you been drinking? Is this an increase in your pattern of drinking or a decrease in your pattern of drinking? Yesterday in the office, I had a patient who had no alcohol history, according to the daughter, but had a history of pancreatitis. He was very demented. I asked the wife, and she said when he got laid off from his job, they used to drink socially, but when he got laid off from his job in '09, he started drinking a lot daily. And so she had to remove all the alcohol out of the house, but in 6 months he created this very serious medical problem for himself. So here's the next question. When a geriatric patient presents as psychotic, what is the most likely diagnosis? Good answer. So clearly the vast majority of you are saying that it's psychosis due to a general medical condition, which is the correct place to go. I'm really glad that no one's answering schizophrenia or brief reactive psychosis here. And it's pretty profound. 16 to 23% of the patients are presenting with some sort of underlying medical problem that may be triggering the psychosis. And things that you may not think about, I think some of them are the obvious, but some of them are not obvious. Hearing loss and visual loss may trigger psychosis. Someone who really can't see may be seeing shadows and then misinterpreting what the shadows are. For someone who is having some even mild cognitive impairment, diminished hearing even from cerumen impaction, they may misperceive that people are talking about them, and they may become very paranoid about that. So being able to look at a variety of medical issues, it's a real easy way and a great place to make some good intervention. You really want a very careful history, and it goes back to what you learned years ago. It's history, 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 and that's often where the answer is in the history about what's going on. We know that psychosis can be broken out into early onset, which is usually an underlying psychiatric illness or a substance use issue, and late onset can be with or without dementia. And just helps you go and coordinate what is where. So if someone had a long history of psychotic disorder or psychotic episodes, then you're into someone who had an early onset as opposed to if someone had a late onset. New onset, it would be another way to look at that. So what's your favorite agent? Not for personal use, but for calming an agitated patient. You answered that one really quickly. So for the vast majority of you, you like Haldol, a couple of you like Ativan, and about 3% of you, or one person in the room, likes Thorazine. So let's take a look at this. When an older adult is agitated, for safety reasons, you need to calm them down and you need to create a safe environment, or you can't do what you're really skilled at doing, which is getting good history and doing the detective work that all of you like doing to get the correct diagnosis and correct treatment plan in place. But beyond medication, there are other things that really you should be thinking about. Quiet setting. For those of you who have been, how many of you are aware of what's going on in the Stratford ED? Okay, so there are 4 beds that are being set aside in Stratford for older adults, and one of the things, there are 2 very important things about that space. One, it's a quieter space so that it'll help diminish any agitation with these patients, and the lighting's being dimmed a little bit. So, you know, right off the bat, it's a quiet room, and by having lower lighting levels, you're able to de-escalate the behavior. In terms of dementia in nursing homes, what we are well aware of is that the #1 treatment is not medication for these people. It's environmental, and it's having the right environment design, and that holds true in the emergency department as well. With rare exception, just a lot of education about what's going on with these people is very helpful to calm these people down. So a word on Thorazine, because every so often I see this, by the way, is the real Thorazine ad. This is This is the old Smith, Kline, and French, which became Smith, Kline, and Beecham. We don't have to go through that. But this is the real ad. Would not fly through the FDA today at all. But here's the question. What's the conversion of Thorazine to Haldol? Because I do see Thorazine every so often tried, and then the call is interesting. Did you know you could convert Thorazine to Haldol? So the majority of you felt that it's 10 milligrams or 10 of Thorazine is 1 of Haldol. That explains an awful lot. About a quarter of you thought that it was 50 to 1, and one lone person thought that it was 100 to 1. Dr. White, did you answer? It is D. Good job. So when you're giving Thorazine, Thorazine is a lower potency antipsychotic, which is a term that you don't hear very much anymore. It's a very sedating medication, but it's not a very powerful medication. So if you compare it to Haldol, you would have to give 100 milligrams of Thorazine to get the same power that you're getting in terms of antipsychotic effect of Haldol, which is why we don't use that much Thorazine. It sounds cool, it's a great name, but in terms of managing agitation and aggression, not a very good choice for patients. This data actually comes out of the practice guidelines for the treatment of delirium, which were put out by the American Psychiatric Association. And what their recommendation is for treating agitation, particularly in the delirious older adult, is Haldol, 0.5 to 1 milligram every hour until sedation is achieved. And what's important to understand is that the rates of onset are pretty long. For oral Haldol, you're talking about 1.5 hours, and for intramuscular, you're talking about 45 minutes. So the issue is, the reason it's an hour is you want to know if the dose you just gave is going to work before you go for the next dose. IV Haldol, interestingly enough, has the same rate of onset of action as IM. So really, if you can get close to the patient, that's the reason to use the IM preparation over the IV, and we'll get into more why you shouldn't use the IM. In practice, this is the practice recommended guideline, but in practice, this dose may be very low. And for someone who has underlying psychiatric illness, someone who has a history of schizophrenia, of bipolar disorder, of psychotic episodes due to a whole host of reasons, you may be going at higher doses. In a younger patient, it's common, and the data supports about 10 milligrams of Haldol for sedation, but in an older patient, you may be using 2 milligrams, you may be using 5 milligrams. This is a practice guideline recommendation, but in actuality, we may be pushing the doses higher. The point, I think, to take away from this is that in rapid tranquilization, rapid is a misnomer. What's rapid to many people may not be rapid to us, and what the recommendation is give a dose and then wait an hour and give the next dose to see if the first dose worked. And I think that's the important concept here. IV Haldol is not FDA approved. And it's not FDA approved because IV Haldol presents the risk of torsades. So if the patient's not monitored, and this is one of those issues that's important for you to take home, because we see this, and we see this more regularly than you think. The antipsychotics as a class are cardiotoxic. They cause dysrhythmias. That's one of their major side effects. We know that Seroquel will cause QT prolongation. We know that Geodon causes QT prolongation. These are facts. They're in the package inserts. We know that IV Haldol will lead to a more advanced VTAC. And if the patient's not monitored, you're really putting yourself and, more importantly, your patients at risk, because there's no warning that this is going to happen in someone. So rate of onset 45 minutes, same as intramuscularly. The literature suggests that if you're going to go this route, it's a 10 milligram bolus followed by 5 to 10 milligrams per hour, which I think is a very hefty dose. And it's hefty because the other thing that's important to know about the IM and the IV prep is it's double the bioavailability because you've bypassed first pass metabolism by the liver by not giving it orally. So when you're giving a 10 milligram bolus, which is why I think this is high, you're really giving 20 milligrams. And just to hammer that point home a little bit, here, if you go the intramuscular route and you're giving 1 milligram, you're actually giving 2 orally. Does that make sense to everyone? Because that's important. Out of the atypicals, what the literature is supporting in the older adults is really risperidone as the most well-studied of the drugs in an emergency setting. The recommendation is about a half a milligram every 2 to 4 hours to a maximum dose in the elderly of 2 milligrams in 24 hours. What we know about risperidone is that once you cross 2 milligrams in the elderly, you lose efficacy and all you do is start increasing side effects. So that's why the 2 milligram cap. There's data on some of the other atypicals, a lot of it's case reports. Some of the atypicals actually have more serious warnings about use intramuscularly in the elderly because there were deaths. We don't have to get into that because that's not what the recommendation is. And so if you wanted to not use Haldol, your backup choice would be Risperdal. But the other thing to remember is you can't use the Risperdal intramuscular because it's a long-acting Risperdal that will take 2 cycles, so 4 weeks to start working. But I've seen some people try that, thinking that it's an immediate onset. It's not an immediate onset. It's a long-acting. So save money. Don't do that. A couple of you said that you liked Ativan, and the data on benzodiazepines, when you dig into it, is actually worse in many ways than the data on antipsychotics. There's pretty compelling data linking benzodiazepine usage to strokes. For the geriatric patient, these can disinhibit the patient. You're hitting the GABA receptors. You can really have a paradoxical effect with these drugs. And while you may get an immediate sedation, benzodiazepines, old term minor tranquilizers, antipsychotics, major tranquilizers. So you get that immediate tranquilizing effect, but the long-term use, especially when there's a bed crisis and we can't move people, is you may see the patient actually disinhibit in front of your eyes. And while a milligram may have worked a couple times, now it's not. Now you're up to 2 milligrams, and the patient's getting more agitated. So be very careful about disinhibition. The literature actually does not recommend the use of benzodiazepines for acute agitation in the elderly. However, if you have an older adult who's withdrawing from a substance, particularly alcohol, this is the treatment of choice if they're agitated due to alcohol withdrawal. So no for acute delirium, yes for substance-related withdrawal. While I'm aware that many of you may not stay with us in New Jersey, you need to be aware that the New Jersey system is not the national system. In fact, when we talk about psychiatric hospitalizations, it's widely variable from state to state. I know that your colleagues in Michigan don't or rarely have access to psychiatry in the emergency department. They're pretty much on their own with it's the ED doc who's doing the treatment and the intervention. And if you're lucky enough to have a friend who's a psychiatrist, sometimes it's a phone call. But they really feel like they're out on their own. And there are other models. There are models of screening centers that are not in a hospital, that they're removed from the emergency department. And New Jersey actually has been considering that. And realize that the screening center that you all have access to is a screening center. It's not a treatment center. So the decisions there are really hospitalized or not hospitalized, and most families are coming in thinking it's like the peanuts with psychiatric treatment literally at 5 cents. But that's not what they were ever designed to be. And we know the system is very broken. In Pennsylvania, families can petition for psychiatric hospitalization. And we often see more often in Camden, but sometimes over at Cherry Hill, we see families coming in thinking that they can sign people into the hospital, but New Jersey law doesn't allow that. And the screening laws, the involuntary hospitalization laws, are an area where the states have independent rights. So you really have to be aware of what state you're practicing in and what their law says to understand the ins and outs, because they do vary pretty widely. New York is different from New Jersey, Delaware is different from New Jersey, and so on. The concept in terms of psychiatric hospitalization is least restrictive setting, which I think is why at times there's a lot of friction between the emergency room doctor and the psychiatrist, because while you may feel the patient should go in to get treatment, if the psychiatry department's operating under least restrictive setting, if we're not communicating, there's a source for friction and a lack of understanding. And the more we communicate with each other, and we are resources for you, the better our care of the patients ultimately will be, because you are dealing with families who have misconceptions in the first place. When you commit someone, I don't know if you're aware of this, but you're really taking away the patient's rights. And in New Jersey, it's very serious. If you have a gun license, you lose your gun license. For those of you who've been on when unfortunately we've had to commit a police officer, they can lose their job. They can no longer carry a gun. There's a concern that if you meet involuntary criteria that you're a danger and the state may not give you back your gun license. Physicians can lose their medical license for being committed. So it's a very serious proceeding. And it's taken very seriously, which is why New Jersey holds the patient's rights so high, and as opposed to Pennsylvania, where you can take away the patient's rights a little bit more rapidly. In terms of managing the geriatric patient in general, the careful assessment's really the key, because they're a mixed bag. They present atypically. They may not be very forthcoming with a lot of information, especially mental health information. This is a generation, remember, that isn't comfortable putting their personal things out there. This isn't the Oprah generation. These aren't people who go to cocktail parties and talk about what antidepressants are they taking or what anxiolytics they're taking. I mean, they barely talk about are they taking hyperlipidemic medication? I mean, these are very private people. And these are people who need more time to be able to give you the information, which is counterproductive in an emergency department where you need the information very quickly. So realize that not only being careful, but you may have to go back. You may have to get the information in snippets on these people, because they may not remember what they're telling you until you go back and say, oh, I forgot to mention X, Y, and Z. In terms of managing agitation acutely, calm environment. If you need to use medication, Haldol is the drug of choice. You want to be able to do this in a methodical method. You need to wait the hour or so before you're dosing again if you're going to rapidly tranquilize someone. Try to minimize the use of benzodiazepines unless you're dealing with acute substance abuse. All of you are on the front lines, and you can make a difference in managing these patients. And hopefully, when you see an older adult, you'll be a little more excited because they're a diagnostic challenge, rather than, oh no, get out of my ER, which takes us back to 1972. Any questions? Everyone? Okay. Thanks. Have a good day.